The title of today's lecture is The Child with Edema, and what we will be trying to do, or what I will be trying to do during the course of this lecture, is trying to correlate what you've learned in physiology with clinical practice. So during the course of this lecture, I'll be introducing you to edema, recapitulating on what you have learned in physiology. I'll be dealing with the pathophysiology with clinical relevance. We'll be touching on etiology, and we'll be moving on to a clinical approach to edema with history, examination and investigations, and finally I'll be just touching on the principles of management just for completion's sake. So to introduce you to edema, edema can be defined as a clinical condition characterized by accumulation of excessive fluid in the interstitial space. So this is a clinical definition for edema, and edema is relatively common in clinical practice. There are specific times and types and terms given to various distributions of edema. Firstly, the term anasarca is used when the child or the patient is severely edematous, where the entire body is full of fluid, and there can also be localized fluid collections. If there is excessive fluid in the intra-abdominal cavity or in the peritoneal cavity, you call it ascites. If there is excessive fluid in the pericardial cavity, you call it a pericardial effusion, and if there is excessive fluid in the pleural space, you call it a pleural effusion. So these are all localized types of edema, which stay with the definition of an excessive amount of excessive amount of fluid in the interstitial space. Now, just to touch on pathophysiology, around 50 to 75% of the human body is water. I'm sure you know this from your physiology lectures. And what you need to remember is the distribution of water, or the amount of water, the water content of the person is dependent on the age and the gender of the patient. Now, newborns, very small babies, they tend to have much more water than an elderly patient. In a newborn, up to 75% of the body weight is thought to be composed of water. In adolescents, it's somewhere in between, around 60%, and the water content in elderly is lower at around 50%. Now, the water content of females is thought to be 2 to 10% less than in males, and this is solely because of the increased fat content in the female body habitus. So the more fat content there is, the less would be the water. The less would be the water content, or the percentage that is composed by water. So let's touch on or recapitulate what you've learned in physiology regarding the body fluid compartments. So the total body water constitutes about 50 to 75% of the total body weight. We just noted that it's dependent on age and gender. Now, of this total body water, 2/3 lies in the intracellular compartment, and 1/3 lies in the extracellular compartment. So 2/3 lies intracellularly and 1/3 extracellularly. And the extracellular compartment, that's the water that lies outside the cells, is divided into two components again. One is the intravascular compartment, or the fluid that lies within the blood vessels. This accounts for 1/3 of the extracellular volume, and the interstitium, which is the rest of the extracellular compartment. This constitutes about 2/3 of the interstitial compartment. And the Starling forces that you learnt in physiology are what determines the fluid distribution between the interstitial and the intravascular compartment. So alteration in these stalling forces would move fluid either from to and from the interstitial component, and thus stalling forces are extremely important when talking about edema. So what are the determinants of fluid distribution? Now, the capillary hydrostatic pressure. This tends to move an increase in capillary hydrostatic pressure tends to move fluid from the intravascular compartment into the interstitium. The plasma oncotic pressure, in turn, which is determined by plasma proteins like albumin. Now this tries to keep fluid in the intravascular compartment, or moves fluid from the interstitium into the intravascular compartment. And capillary permeability. If there is a loss of the permeability of the capillary wall, this tends to leak out fluid from the intravascular to the extravascular or the interstitium, extravascular space or the interstitium. So any of these can really constitute edema. Now, in a normal person, exit of fluid from the intravascular space at the arterial end, because the arterial end at the capillary bed, the arterial end, the pressure is higher than at the venular end. So there is a slight exit of fluid from the intravascular to from the intravascular space to the interstitium because of the high pressure, because of the high hydrostatic pressure. And this exit of fluid is balanced by an influx of fluid from the interstitium back into the intravascular space at the venular or the venous end. Now, this balance is critical to maintaining the fluid in the interstitium, and any excess fluid that remains in the interstitium due to a difference in the efflux at the arterial end and the influx at the venular end, any fluid that remains in the interstitium is removed by your lymphatic system. So any excess fluid will be removed by the lymphatic system. So what determines edema, or how is edema formed? What is the pathogenesis of edema? We just touched on the stalling forces active at the capillary bed. Now, if there is an increase in capillary hydrostatic pressure, this would move fluid from the intravascular compartment into the interstitium. In turn, if there is a reduction, or if there is diminished plasma colloid osmotic pressure, fluid cannot be kept in the intravascular compartment and it will leak out again into the interstitium. If the capillary endothelial bed is damaged, or the capillary endothelium is damaged, again fluid would leak out from the interstitial compartment to from the vascular compartment or the intravascular compartment to the interstitium. So this also would lead to excessive fluid in the interstitial compartment. And I mentioned that the lymphatics are responsible for removing excessive fluid in the interstitial compartment. So an obstruction to the lymphatic system, or diminished lymphatics, this would in turn hinder the removal of fluid and have fluid accumulation in the interstitial compartment. So an increase in capillary hydrostatic pressure, a diminished plasma colloid osmotic pressure, damage to the capillary endothelium, and lymphatic obstruction. One of these four entities will be one of these entities. If there is edema, it's due to one of these four entities. So it's easy to work out. So if you find a patient with edema, all you need to do is find out which of these four entities the edema falls into, and we'll sort of I'll clarify how you work things out in the course of this lecture. Just a few words about a transudate and an exudate. What is a transudate? What is an exudate? Now, an exudate is what is called inflammatory edema, and this is due to an increase in capillary permeability, loss of capillary integrity, and it basically is not only the fluid, the plasma proteins as well leak out from the intravascular space to the interstitium. So because your capillary permeability is lost, the plasma basically leaks out from the intravascular space to the interstitium. So because it is plasma that is leaking out, this fluid is protein rich and has a high specific gravity. A transudate, on the other hand, is due to a change in the hydrodynamics at the capillary bed. So it's either due to a loss of plasma oncotic pressure or due to an increase in plasma, an increase in capillary hydrostatic pressure. So loss of oncotic pressure or loss of oncotic pressure or increase in hydrostatic pressure leads to fluid leaking or mainly water leaking out from the intravascular space to the interstitium. So this, because it's water that leaks out, and because the capillary wall integrity is maintained, the proteins do not leak out. So this fluid, or the transudate fluid, is poor in proteins and has a low specific gravity. Now, how do you work out the etiology of edema based on your Starling forces? Right, so if there is increased pressure at the venous end, the hydrostatic pressure would lead to an increase in the hydrostatic pressure of the capillary bed, and this would leak out fluid. So what would cause an increase in systemic venous pressure? So when your heart is not pumping blood adequately, the pressure at the venous end would increase. So if you have right-sided heart failure, or what is called constrictive pericarditis, where the pericardium is full of fluid and constricts the heart and hinders the pumping mechanism of the heart, pressure at the venous end would increase, and this increase would increase the capillary hydrostatic pressure, fluid would leak out, there will be edema. Now, there can be local venous obstruction, or only certain blood vessels, without the heart being involved, certain blood vessels can be occluded, like a superior vena cava obstruction or the obstruction of the portal vein, and this would again increase the hydrostatic pressure at the venous end of the capillary bed and raise the hydrostatic pressure, causing edema. But here the edema will be localized. So if you have a superior vena cava obstruction, your edema will be in the head and neck area, not the rest of the body. Now, another mechanism which increases the hydrostatic pressure is when there is fluid overload. So this is usually due to a problem with the excretion of fluid. So when your kidneys are damaged, conditions where there is inflammation of the kidneys, which is acute glomerulonephritis, or there is acute kidney injury, and your kidneys are not pumping, not excreting fluid adequately, there is an increase in your intravascular volume, which leads to an increase in hydrostatic pressure and leakage of fluid and edema. Again, this would be generalized. What leads to a loss of plasma oncotic pressure? I mentioned that a loss of plasma oncotic pressure would again lead to edema. What leads to a loss of plasma oncotic pressure? Right. So firstly, there can be reduced synthesis of plasma proteins, which are essential to maintain the plasma oncotic pressure, or which basically maintain the plasma oncotic pressure. So when there is a reduced synthesis of plasma proteins, like in protein calorie malnutrition, the protein synthesis is hindered, there would be loss of plasma oncotic pressure and edema. The liver is the organ that forms most of the plasma proteins. So in liver failure, your plasma protein production is less, reduced plasma oncotic pressure, and you get edema. Or there can be an increased loss of plasma proteins. Now, if this occurs in the urine, there's a condition called Nephrotic Syndrome, where due to some reason, due to really unfound reasons, the kidney starts leaking out proteins. So your plasma oncotic pressure or plasma protein level falls, or the serum albumin level falls, there's loss of plasma oncotic pressure, and there is edema. Proteins can also be lost in the gastrointestinal tract, or from the gastrointestinal tract. This condition is called a protein losing enteropathy. So again, when the GI tract is losing proteins, plasma oncotic pressure is reduced and you get edema. What causes an increased leakage increased capillary leakage or increased capillary permeability? Allergies. Patients who are allergic to something or get an allergic reaction, they usually have generalized edema. If the patient has severe bacterial infection, which is called sepsis, now this also can lead to increased permeability at the capillary bed, or increased permeability of the capillary wall and leakage of fluid. Angioedema is another condition that again leads to leakage or increased capillary permeability. And patients with dengue infection, which you've all no doubt heard about, again these patients also have an increased capillary permeability. So all these conditions lead to increased fluid leakage due to capillary permeability or increased capillary permeability. Impaired lymphatic flow, or what we mentioned that lymphatics are responsible for removal of excessive fluid at the interstitium. So obstruction or impairment in the lymphatic flow would also lead to edema. So congenital lymphedema is a condition where the lymphatics have not formed adequately. Wuchereria bancrofti or Bancrofti infection, or which is called filariasis. This infection is called a parasite, basically occludes the lymphatics, and the lymphatics do not function. Surgically, after an operation, lymphatics can be damaged, and when you have irradiation in radiology, various irradiation techniques that are used sometimes as treatment for malignancies or cancers can damage the lymphatics. So all these things constitute damage or malfunctioning of the lymphatic system and edema. So how would you define the cause of edema, or the cause of edema clinically? Now, if the edema in your history, when you take a history from a patient, if the edema begins around the eyes and then progresses to the rest of the body, or the edema is worse early morning as the patient wakes up from sleep, and it reduces towards the rest of the day as the day progresses. Now this is usually due to a problem in the kidneys. So that description would constitute edema so you need to suspect that there is a renal or kidney problem here. Cardiac edema, when there is a problem with the heart, we said congestive cardiac failure or pericarditis, this would cause what is called a dependent edema, and your edema would be in the dependent areas like the lower limbs. So if only your lower limbs are edematous, that should make you suspect that a cardiac cause is what is responsible. Now, if the edema is due to a hepatic cause or problem with the liver, or if it is due to constrictive pericarditis, where the heart cannot function due to a problem with the pericardium. This edema usually begins in the abdomen or intra-abdominally, and there is ascites, as I mentioned earlier, and then progresses to the rest of the body. So if the edema began there and then progressed, that you need to suspect a hepatic cause or constrictive pericarditis. Now, if your edema is asymmetrical or involving only one part of the body, say one leg is involved and the other leg is normal, now this is due to usually a local lymphatic problem, or it can be inflammatory edema, like say a patient has a cellulitis or infection of the subcutaneous tissues, which has led to an increase in capillary permeability. So if he has an infection of one leg, the edema would be confined to that leg. Or if the edema of the lymphatics in one leg are obstructed, say a patient with filariasis, as I mentioned, that leg would only be involved. And there can be local venous obstruction. I mentioned obstruction to the superior vena cava would have edema in the head and neck area. Now, if there is very, very severe edema, like so the entire body is affected with edema, and the patient is like basically a Michelin man, that would usually be due to nephrotic syndrome, which is a condition, as I mentioned, where proteins are lost from the kidneys. Now, the other symptoms that the patient presents with also give you an idea as to what the cause of the edema is. Now, if the patient with edema has also difficulty in breathing, and he has difficulty in breathing when he exerts himself, or he cannot lie down properly because there is fluid accumulation in the lungs, this would be due to a cardiac problem or congestive cardiac failure. If the patient has jaundice and a bleeding tendency because bilirubin is not removed, this would be due to cirrhosis of the liver or a liver problem. So if there is jaundice with the edema, you need to think of a liver problem. If there is frothy urine, this would denote protein in the urine, and you need to suspect the nephrotic syndrome. If the patient has blood in the urine, or there is a reduction in urine output, you need to suspect what is called a nephritic syndrome, or an acute inflammation of the kidneys that has led to usually a transient malfunction of the kidneys or dysfunction of the kidneys. If the patient presents with diarrhea, you need to suspect, and edema, you need to suspect what is called a protein losing enteropathy, or that the proteins are being lost with the diarrheal stools. And if the patient is malnourished and has all features of malnutrition, the patient is emaciated, you need to think of poor nutrition leading to a low protein intake and reduced protein synthesis, and that would constitute the protein energy malnutrition, which is termed kwashiorkor. So, how would you examine these patients, or how do you look through your examination? How would you determine the cause of the edema? Now, the general examination or the general appearance of the patient with the anthropometric measurements, your height and weight and body mass index, would give you an idea as to what the cause is. Now, say if the patient is severely emaciated, you need to think of protein energy malnutrition. The distribution of edema, we've already touched on that. If the edema begins periorbitally, you need to think of a renal cause. If there is dependent edema, a cardiac cause. If it begins abdominally, constrictive pericarditis or liver problems. If the patient has other features of nutritional deficiency, like a patient is pale, has what is called flaky pain dermatitis, or other features of nutritional deficiency like like angular stomatitis, and this would constitute again, or would signify protein energy malnutrition. If the patient has features of liver disease, like the patient is jaundice and has what is called spider nevi or palmar erythema, which is a redness of the palm area, this would constitute a hepatic problem and reduced hepatic protein, hepatic protein synthesis. If the patient is dyspneic or tachypneic and has difficulty in breathing, you need to suspect a problem in the heart or cardiac or congestive cardiac failure. And if the patient has an erythematous rash, you need to think of allergies, and allergy causing an increased capillary permeability and urticaria. So your history again points, your examination rather, again points you to the cause of the edema. Now, when you examine your cardiovascular system, you will be able to find features of heart failure. If you examine when you examine the abdomen, there will be prominent abdominal veins. There may be ascites or fluid in the intra-abdominal compartment. You might have enlarged liver, which would again signify that there is liver disease, or it may be the liver may be tender, or it may be painful when you press on it, and this would indicate that there is heart failure again, because fluid is accumulating, because the liver is getting congested, because the heart is not pumping the fluid adequately out of the liver. Your kidneys may be ballatable, or you may be able to ballot the kidneys if the patient has a renal problem. So abdominal examination also gives you a clue as to what the cause of the edema. So what are the principles of management of edema? Now, the principles of management are determined by the underlying cause, and they're dependent entirely on the underlying cause. So what are the basic principles? I'm not going to go into detail here because this is a preclinical lecture. So if the edema is due to volume overload state, where the volume, because there is an increase in the intravascular volume, and that has constituted an increase in hydrostatic pressure, which in turn has constituted edema or caused edema, you need to remove the excessive fluid. So you use diuretics, or a drug that increases the urinary excretion of the renal excretion of fluid. So you increase the fluid loss from the kidney, and you reduce the intravascular volume thereby. Or you can reduce the fluid intake. If the patient is overloaded, you need to reduce the fluid intake, and that would reduce the intravascular volume and reduce the hydrostatic pressure. Now, if the patient has severe hyperproteinemia, or the hyperproteinemia has led to the edema, you can infuse albumin or infuse plasma proteins in the form of albumin or human albumin into the patient, and replenish the lost protein sources, replenish the oncotic pressure, and draw the fluid back into the intravascular compartment. If there is angioedema, or an allergy has led to an increased capillary permeability, you can use antihistamines or other anti-inflammatory drugs like steroids to reduce this capillary permeability, the increased capillary permeability, and thus prevent the fluid from leaking out. And if there is lymphedema, you can use compression bandages to prevent fluid building up. So these are, again, just to highlight how you can use your physiology knowledge into clinical practice. And I think this is the last slide. So if you have any queries, I've given my email address at the in the first slide. You can send your questions and queries and comments to that, and I will try and reply as soon as possible. Thank you.